Welcome to our 22nd Annual Breast Cancer and Cancer Education Forum. Can we give everyone a hand for being here? I'm Dr. Janine Cookerard, and it is my second time. I was here last year and here again this year. Can we give special recognition to our Deputy Supervisor, Dorothy Gooseby? Special recognition for making it here. She had a lot of things to do this morning, but she's here looking beautiful. And Supervisor Don Clavin, who I don't believe is here, but we just give special honor to these people and to our distinguished guests, Jerry Barish. Jerry Barish is a breast cancer activist, president of 1 in 9, the Long Island Breast Cancer Action Coalition. She's an executive director of the Hewlett House, and I had the privilege of interviewing her on WHPC 90.3 Nassau Community College this week. Jerry Barish is a 5-time cancer survivor and has been all the forefront in battle against breast cancer on Long Island since 1988 and has earned the distinction of being New York State's preeminent breast cancer activist. Being the executive director of Hewlett House fulfills a dream and vision Jerry has when she began her own struggle with breast cancer. Jerry vowed a long time ago that given the opportunity, no one would have to go through what she did to battle this dreadful disease alone. Hewlett House is a multi-purpose, professionally staffed facility in a home-like setting for cancer victims and their family and friends. And it sounds like a wonderful accomplishment that has had long longevity in the community. Can we give this a special hand for Jerry Barish? And then we have Dr. Irina Gelman. I'm just going to introduce some of our distinguished guests. Nassau County Commissioner of Health. Dr. Irina Gelman is currently the Commissioner of Health for Nassau County, New York. She was formerly the Health Commissioner of Orange County. Dr. Gelman also was a Fellow of the New York Academy of Medicine and Board President of the New York State Association of County Health Officials. With her preliminary medical background in surgery and clinical care, Dr. Gelman, a Pace University graduate, grew up in Brooklyn and went to receive her doctorate degree from the New York College of Podiatric Medicine. She obtained a master's degree in public health at Nova Southeastern University College of Osteopathic Medicine and has earned a Haney's Academy for Healthcare Leadership certification from Cornell University. Give it up for our Dr. Gelman. All right. And then we have our Dr. Michael Zeidman. Am I saying that right? Okay, Michael Zeidman has practiced surgical oncology. We have a surgeon on our panel with a focus in breast surgery since 2013. After graduating with his medical degree from Northeast Ohio Medical University, Dr. Zeidman completed his residency at the General Surgery at Mount Montefiore Medical Center. He then moved to Mount Sinai Hospital for his fellowship in surgical breast oncology. With his certification by the American Board of Surgery, Dr. Zeidman strives to provide expert surgical care for his patients with benign and malignant breast diseases. Okay, that is Dr. Zeidman. Let's give a hand for him. Dr. Douglas Marks. Raise your hand, Dr. Marks. All right. NYU Long Island School of Medicine. Dr. Marks is an associate professor of medicine at NYU Long Island School of Medicine. Prior to joining NYU, Dr. Marks completed medical school residency and a fellowship at Mount Sinai Hospital and Columbia University Medical Center. Dr. Marks has expertise in treating lymphomas, chronic leukemia, breast cancer, among other conditions. That is our surgeon, Dr. Marks. Oh, he's not a surgeon. He's just a breast oncologist. All right. Okay, he is a breast oncologist. So we thank you for being here today. And we have our cancer survivors. Cancer survivors, raise your hand. Okay, that is Miss Eartha T. Washington and Tanya Herring. Eartha T. Washington, raise your hand so we know who you are. All right. And Tanya Herring. Okay. Thank you so much for being here with us, cancer survivors and our distinguished panel. We have some questions for you that I think everybody would like to know. And let's just start by saying this occasion brings us all together because I think everybody's life has been affected by cancer, be it breast cancer, prostate cancer, whatever cancer it is. I think we all come to the table here, listening and hoping for education, as education does give us how to handle and how to deal with and how to help in the community and with our families as well. Can we start with just the prevalence? And I will ask anybody that can jump in and tell us the prevalence of breast cancer. We'll start with breast cancer first. The prevalence of breast cancer in not just Long Island, but the breast cancer globally, how it has really changed over time, Nassau County.
I will take that question. Good afternoon, everyone. Thank you for having us on this very important panel. The prevalence and incidence. Cancer is the second leading cause of death in the U.S., following heart disease. As of 2024, breast cancer remains the most common cancer among women in the United States, and that's excluding skin cancers, which another important topic for another day, especially on Long Island. Accounting for about 30%, and statistically that's 1 in 3 of all new female cancers each year. So that's a significant number. It's very impactful. Over 300,000 people are expected to be diagnosed with breast cancer this year. On average, a woman in the U.S. has about a 13%, and that's 1 in 8 chance of developing breast cancer during her lifetime. As far as the relative context that you asked for, in Nassau County, our breast cancer incident rate is 146.9 per 100,000 women, and that is higher than both the New York State rate at 134.5 and the national average. So it's a very timely conversation, it's a very important conversation, and not just for women, but men as well.
Yeah, you mentioned that it's higher in Long Island. Can anybody give me a little sense of what your thoughts are about why that is, that cancer is more prevalent in Long Island? Have research touched on that at all? Is it in the literature?
It's not in the literature to my knowledge, but my thought on it is that we have a high Ashkenazi Jewish population. And in the Ashkenazi Jewish population, we have a higher incidence of having genetic mutation that can significantly increase your risk of breast cancer.
So yeah, we are actually 100% agree. We are in the top quarter of the country. There are very few counties that rival Nassau and Suffolk County. There has been a lot of research to try to understand why. Oh, am I speaking? Oh, I think it's on. Okay, I'll close it. So we're the top quarter of the country by county. So we're really up there. There's a few counties in Florida that rival us, and also some in California. As Michael said, there is some genetic syndromes that are more commonly seen on Long Island because of a Jewish population, especially. But it's interesting, it's more than that. There was a study called the Long Island Breast Cancer Study that was completed in 2000. It was an NIH study, and it looked at all different types of environmental risk factors. It was not able to find a specific thing like Grumman or our power plants, but we did identify a lot of lifestyle risk factors that are different on Long Island potentially than other places. Women tend to have children later in life on Long Island. There's, in some areas, some higher alcohol intake on Long Island. There are higher family histories and clusters of families that get together. Maybe so one family has a higher incidence, not a genetic reason, but a higher family history that's not genetic, but genomic, we call. And then they meet another family which has that as well, and then they get together, and then they have a composite risk. So there's definitely multiple factors that are going to this, and that study is being repeated again now to see if we can find out, are there any more environmental factors that are being mixed as well, because you will notice there are clusters on Long Island that are even higher than other areas of Long Island.
Are we seeing that breast cancer is a higher prevalence in the African American Black communities as compared to other communities? Yes.
Yeah. Can I grab that?
Sure.
And then I want to go back to
Sure.
the environment, if I might. Yes, there is much higher. I think it's 38% of the breast cancer is in the African American community.
If you can move a little closer to the mic.
I'm sorry.
Yes.
Bad voice, leave me home. So there is a much higher rate of mortality amongst the African American community than in Caucasian. We're not sure if it's access to screening, if it's genetics. We are certainly looking into that and doing more studies and impressing upon our younger people with a background or a history of different kinds of cancers in the family. Breast cancer is a hormonal disease, and so we're looking at other cancers that can correlate to that. Myself, we started the first Long Island Breast Cancer Study Project, and it was done here because we have more open way sites in any one place, in any one state. Most golf courses in any one place, in any one state. We had an underground aquifer system. We had more than most areas of environmental problems than any one place in any one state. The first study was very interesting because as the study got closer to Old Westbury, there was no cancer. And when we looked at that, we realized that the watershed was in Old Westbury. Now, watershed is protected. Was it coming from there, or was it because it was protected? We now are redoing and updating that project. And I have my own personal feelings about our environment and Grumman and things like that, because when we knocked on doors in the beginning, we looked at an area or a street. We looked at an alcove. Where did the water go out? It remained in the center of the alcove. So we started looking at that. We started questioning about the different sites that had things buried that we had no idea. Pesticides and chemicals. We put together the very first pesticide registry in New York State. It took us 4.5 years to do. And it was an amazing project. We were able to get the chemicals off the shelf that was sitting next to bread and teach people the inert ingredients, what was inside these chemicals. We had them put the little yellow slips that you see after a gardener does your lawn. We wanted a number on there so people can see and make a phone call and know what's on there. So I am a firm believer that our environment has a lot to do with our health, but there's a lot more. We have to understand our genetics, where we come from, what we surround ourselves with, and what our history is. What I am seeing today as being involved in advocacy and as a survivor, we are seeing younger and younger women getting breast cancer in their early 20s. And it's coming down between 20 and 50 years old. And it's not just a stage 1. It's a serious breast cancer. So the screening is something that we're fighting for, better screening and for people to know their history. And I tell everyone, speak to your doctor. There is no dumb question. Call our organizations. We're here to help. Call our health departments. We are saving lives and we're living longer and longer. But we hear more information, more education. And I know you know this, knowledge is power.
Thank you for that. One question that I had, I wanted one of the cancer survivors to share her story, particularly as it relates to breast cancer. And then I think that's powerful because one of the things that I think people think that it's you find a lump in your breast and automatically you're scared because it's breast cancer. Not always is it breast cancer. Sometimes it's a benign mass. Tell me your story. How did you find out that you had cancer?
It's funny that you say, tell me your story, because that's how I found out That's part of my story. It was COVID, it was August, and the radiology was finally open. And I said, oh, you know what, it's time for a mammogram. I just wanted to get out the house. And so I went, and a few days later, I got a call from my GYN that they found calcifications. So I had to go see a breast surgeon. And so I went and saw the breast surgeon, and he ordered a biopsy mammogram. And from that, I had to have an MRI biopsy of my breast. And so I go, and they lay me on my stomach, and my boobs hang low, and they're putting me in and out of this machine and they're making marks on me. And then the last time, they actually, they numb you where they think they need to do the biopsy. But that numbing is really for their entertainment, not for yours, because you are not numb at all. And there's a lovely nurse holding my hand who's crying with me and, telling me it's almost over as they stick this needle in, and I'm screaming from the pain. And then here we go. Now, fast forward, because that was in August, but it was a process to get to here. So that was a few days before Halloween. And then on October 31st, 2020, the breast surgeon calls me at 6:30 p.m. while he's having dinner and says, hey, Tanya, just wanted to let you know you have cancer. It's DCIS, and, just call my office in the morning on Monday, and my secretary Gladys will take care. And that was it. And I had to go the whole weekend with this and not tell my family just yet because I had to process it. And so Monday comes, and I call Gladys. And Gladys, I say, hi, Gladys, Dr. such and such told me to give you a call. They found cancer. And she's like, I don't know what he's talking about. I do not see that in your chart. I'll call you back. And from that day to this one, I have never heard Gladys' voice again. She never called me. So Wednesday comes, and I call my GYN, and I said, hey, I never heard back from Dr. such and such, and I'm concerned because he said I had cancer. And she said, can you get to my office by 1:30? I said, yes. And so I get to her office, and she sits me down, and she puts a piece of paper in front of me, and she goes, there are 5 doctors on this paper. The first 2 do not take insurance, but the bottom 3 are just as skilled. I trust all 5 of these doctors. These providers are my friends. I need you to pick one. And the third one on the list name stuck out to me, and it happened to be Dr. Logman. So I call her office, and I say, I need to make an appointment with Dr. Logman because I was just told I had breast cancer. And the lady on the other end goes, Dr. Logman's on vacation, but tell me your story. So I tell her my story, and she goes, okay, I'm going to make you an appointment for November 20th to see Dr. Logman. I said, okay. So November 20th comes in. Dr. Logman's PA comes in the room first. And she goes, hi, Tanya. Tell me your story. So I tell her my story. And by this time, I'm a little tired of telling my story. I want somebody to tell me something. And so then Dr. Logman walks in, and she goes, hi, Tanya. Let me tell you your story. And I just immediately start crying as she's talking, because not only is she telling me my story, but she's telling me my story from the beginning, and she leaves nothing out. And then she says, now let me tell you what we're going to do. So she examines me, and then we go sit in her office, and she presents to me a paper where she drew my breast, and she's looked at every test I had, and everything, and she said, now I need you to see a plastic surgeon, and he doesn't take your insurance, but I want you to see him anyway. So Dr. Logman had already had my plan out. She knew exactly what was going to happen. But at this time, I'm just going for a lumpectomy. So I go and I have the lumpectomy done, and I think all is well, and then I find out on January 19th of 2021 that I actually have cancer throughout my breast. And then she tells me again, I need you to go see Dr. Marks. That one right there. And she says, don't worry, he's going to take great care of you. I trust him. I said, okay. And I go see Dr. Marks. And and my story got better. Because from the moment I met Dr. Marks, I felt I was in good hands. His office, his staff, they broke everything down. But you need to know I never had a lump. I never had discoloration. I never had anything different. My breast never looked different. Wow. It was always the same. What saved my life was getting screening. There was nothing, if I had waited, I don't think my turnout would be the same. If I would have skipped 2020 and waited to 2021, my stages, Dr. Marks, you may have to help me, the stage 1, 1A, and 0. So I would, those probably, because Dr. Marks, I'm going to jump ahead, Dr. Marks did something that I thought was really incredible. Dr. Marks started treating me before I had the mastectomy done. And it stopped my estrogen. It stopped my estrogen and progesterone from growing. Because I was estrogen positive, progesterone positive, and HER2 negative. Okay. And I want you to see how incredible Dr. Marks is, because Dr. Marks has hundreds of patients, but guess what? He knows my story.
That's incredible. How many years has it been since you've been a
I am
survivor?
3.5 years.
That's an awesome story. Just tell, yeah.
This was not planned, and I totally made my weekend when I saw your name on this thing. So this was not planned.
In the mic, we can't hear what you're saying.
This was not planned. It was a total surprise when I saw your name, Tanya, on the panel, and it made my weekend. So
Yeah.
I'm so excited to be here with you.
Yeah. I can say when you are an excellent practitioner, physician, patients will remember you because you make that kind of impact. So thank you for that relationship that you two was able to build through this story. So talk to me about how cancer is diagnosed, breast cancer in particular. Ms. Tanya told us about how she was diagnosed, but tell us how is breast cancer diagnosed? What is the typical screening?
Yeah, I'll take this one. Well, hopefully it's diagnosed by mammogram, because as Tanya pointed out, the most common presentation with breast cancer is going to be no symptoms at all. We don't screen for every cancer. There's a reason we screen for breast cancer. And hopefully when we catch it on screening, we're catching it early. But that's not always the case. Sometimes you will have what we call a palpable mass, a lump that you feel in your breast. You may have discoloration of the skin. It may be very red and look like an orange peel. There are many different ways that breast cancer can pop up, but typically it's found on a screening mammogram. And when we find an abnormality on mammogram, it's too early to get super nervous about it. We need to investigate it further. So the typical next step is going to be getting a core needle biopsy. And most of the time, the radiologist will numb the correct location, and we'll have the same, it still hurts. Well, to your point, Tanya, I have a lot of patients that tell me the core needle biopsy was much worse than the actual surgery for the cancer. And that core needle biopsy is super important, though. We don't just rush to take out something that we see that's abnormal on the mammogram. Even if we knew it was cancer, if someone told me, this patient has breast cancer, I still would want that biopsy first, because there are many different types of breast cancer. And not every breast cancer is treated with surgery first. Sometimes the type of breast cancer a patient has calls for chemotherapy first. And so it's very important to get that tissue diagnosis. Now, when they stick the needle in, they're usually doing a few passes of the area of concern. That way we get a good representation of what's going on there. They'll also do something called vacuum-assisted biopsies. So we're really sucking out a lot of the tissue and getting a firm diagnosis before we start treatment. And so that's typically how the diagnosis of breast cancer is made. Imaging first, and then it's called a core needle biopsy second.
And how early should mammographies happen? Are we talking what age, typically?
Yeah, so it really depends. For the average risk woman, as of now, guidelines say that we start at 40. And continue annually in perpetuity. There are some guidelines out there, which I personally disagree with, that say once you reach a certain age, you may not have to get your mammograms anymore. I am in the camp that's firmly against that. I think you should, as long as you're drawing breath, you should be getting your mammogram. Because even if you're too elderly or sick to undergo surgery, there are still options that we can give you, such as medication to block estrogen and progesterone, that will at least you won't cure the cancer, but it'll at least keep it at bay. Okay, so those are for average risk women. This is why it's important to know your family history. You may not be the average risk woman. You may need to get screening, mammogram, sonogram, and possibly even MRI as early as age 25, depending on your family history and genetics.
So I wanted to highlight actually a couple of points that were made. In terms of recommendation, the American Cancer Society recommends, as was said, 40 to 44 have the option to begin annual screenings, 45 and older have annual mammograms, and the recommendation that everyone is kind of at odds with is women aged 55 and older can switch to biannual, so every 2 years. Many doctors do not necessarily agree with that, and as we've heard, it's very much based on your genetic predisposition, also family history and other risk factors. But I do want to highlight some encouraging news. The encouraging news is that women diagnosed with localized breast cancer, the 5-year relative survival rate at this point is 98%. So we cannot stress enough the importance of early detection through screening. It is crucial for catching breast cancer at its most treatable stages. So it's really, really important to get that screening early on to ensure that the treatment that is available and the treatment that's ever changing is there for you. In Nassau County, we're proud that 77% of women aged 50 to 74 have had breast cancer screenings according to guidelines. So that's a great statistic, but we're hoping that more of our residents get out there and get screened, starting with that van right over there. So if you have not had your screening, by all means, it's here. And if you're more comfortable with having your doctor, by all means, please speak with your doctor and present for your screenings. And definitely make an appointment for your loved ones. For Valentine's Day, there's no better gift than scheduling that appointment.
So that's great, the diagnosis of breast cancer with the mammogram. Now, are there certain cancers that have a higher mortality rate? I'm hearing of the triple negative, I'm hearing of the BRCA and all of these kinds of different ductal cancers. Are they different in terms of the survival rate?
Sure, yes. There are many different types of breast cancer. So, there are many different types of breast cancer. I think when I talk to a patient, the first thing I try to do is teach them about their type. We are hearing about this from Tanya about estrogen receptor positive breast cancer, which is hormone-driven breast cancer, which makes up about 70% of the types of breast cancers that are seen most frequently. But there are some very rare subtypes that are less than a couple percent. But then the other types that people may be familiar with is like what's called HER2 positive breast cancer or triple negative breast cancer. And because medicines have become so much more effective, there's what is called prognosis and what is called prediction, like how well someone will do. And HER2 positive breast cancer used to have the worst prognosis. Now, because the drugs are so good since 2000, they do the best in many situations. So I encourage, if someone does have a diagnosis, that they speak with someone who's really familiar with treating breast cancer, because what you read online has changed a lot, even in the past 15 to 20 years. But the most difficult type in terms of prognosis and prediction still at this point is triple negative, although the treatments have improved. And that makes up about 10 to 15% of breast cancer.
How prevalent is breast cancer in men?
It's very rare. So it's 1% of all breast cancer diagnoses are men. An individual man's risk is much less than 1%, maybe around 0.2, 0.4%, even in a man who has a BRCA mutation. Yeah. So a woman who has a BRCA mutation may have a risk of breast cancer, depending on which BRCA mutation they have, of around 40 to 60%. Whereas a man with a BRCA mutation still has less risk than a woman without a BRCA mutation. So I tell patients, and I have a number of men who see me. I have a club of men, but it is a small club. I think the most important thing is for men to be aware that it can happen. It is not something that they should be living in fear that they're going to get, even if they have a family member, because it is rare, much less than 1%. BRCA mutation is about 4% in men, which is very rare compared to, like I told you, 50 to 60% in women with that mutation. But if a man feels something or notices something different in their chest, they should definitely bring it to their doctor's attention, because sometimes these are overlooked and it can happen.
So are men also invited to have a mammogram as well as women annually, or is this something that is not as encouraged among men?
It's so rare.
Because it is
You're
rare.
much more likely to find a bunch of junk
Okay.
and cause the person a big amount of distress. It is even so rare in BRCA mutated patients that even that is questionable whether they should. In men that have a history of a breast cancer, the recommendations are up to deciding with the doctor. But for example, for my men who have a history of breast cancer, I do perform mammograms on the involved side if they haven't had a mastectomy, and the contralateral side as well. But that's a pre-selected group of people that have already demonstrated that they have gotten breast cancer. But men with a family history of breast cancer, or men with, just who are concerned, a mammogram wouldn't be the first step. First step would be talking to your doctor and having them examine you. And if you notice something, that's not screening, then that's investigation. And investigation is fair for anybody.
So when you talk about investigation, are you talking about self-breast examination where you're feeling your breasts for any possible lumps? Is that what you're alluding to?
If you notice something different about your body, it's no longer screening, it's diagnosis. That means that something is there. It may still very well be benign, and that applies to women too. If you feel something, even if you had a mammogram 7 months ago, that doesn't mean you need to wait till your next mammogram, because that's not screening, that's diagnosis. And then you go to the doctor and you decide, and it could be that week that you get a mammogram, and if that mammogram doesn't show something but it still doesn't feel right, that week you can get an MRI, or some more tests to figure it out. So there's screening, which is you feel great and you're just getting checked just because, and that's really, really important. And then there's something you feel or notice different about your body, which is whenever it happens, if you feel something, say something.
So you can have a mammogram maybe more than once annual,
Of course.
right? So, but a lot of people don't know that insurance does cover a mammography, an annual mammography that you can, right? You can go annually, that your insurance will cover for that. Tell me about when it comes down to after you've been diagnosed with having breast cancer, what is the typical treatment, medication regimen for individuals who have been diagnosed with cancer?
Yeah, so that ties back to what Michael was talking about as well, is that there are different types of breast cancer, and there are some patients within the same type that require a lot more treatment than others. So that's why I find my job so interesting, is because even though I just treat breast cancer, my patients are receiving different treatments based on their personalized medicine. For example, you may have a patient with a hormone-driven, estrogen-driven breast cancer that does not require chemotherapy, because we can do some tests like Oncotype, these tests that we do on the tumor to look at how aggressive that tumor is, and use that to predict what treatments you need to lower the risk. So if you have a patient who has a very low risk of the cancer coming back, you don't need to give them that much treatment to cure them. But if they have a very high risk of the cancer coming back, you're going to give them more treatment to cure them. And that more treatment should be determined on the type of breast cancer they have. So I don't want to sound too much about Tanya's story, which she said herself, but some women are diagnosed even before they go through menopause, younger women. And we can take advantage of that by lowering their hormone levels to that of a menopausal woman, and sometimes avoid chemotherapy because that treatment is so effective. Whereas that wouldn't be effective for a woman whose tumor was not driven by estrogen. And so it's very patient dependent, but it's based on their degree of risk, how much you treat them. How the intensity of the treatment should be based on their risk for recurrence. You don't need to cure someone many times, you just need to cure them once. And so you need to choose the treatment that's appropriate for their level of risk.
So chemotherapy, is that an oral medication or is it IV, meaning that it goes in your bloodstream? How do we do chemotherapy?
So we do have some oral chemotherapies, but they're not as common as IV chemotherapies, and that's partly due to the fact that you can get it into someone's body, sometimes even with less side effects by IV than oral, because oral has to get absorbed and can cause all types of. But we do have some oral chemotherapy drugs, but you'll probably know, people in this room have known patients, that the majority of the treatment with chemotherapy is usually IV.
It is IV. And is that done in the hospital setting, or is it done in the home setting? Where is chemotherapy usually?
So if chemotherapy is needed, it's almost never given in the hospital. It's always given under supervision by a doctor and a nurse in an infusion center. There are reasons for that, not necessarily because chemotherapy is so dangerous when it's going in the body, but because it's something that our body can have reactions to in terms of like allergies, and it's done in a monitored environment. But not like a hospital environment, more an environment that we have the allergy medication if someone has an allergy, and also so we can check their blood work and make sure it's safe for them to get it. And so we can do all of that at one place, and that's in like an outpatient doctor's office with an infusion center usually.
So let's just go back to when you do the biopsy. When you have the biopsy, what are you looking at? Are you looking at the type of cancer it is? And are you also looking at the lymph nodes that are involved when a cancer is diagnosed? What exactly are you looking for when?
Right, so we're looking at the findings that we see on imaging. So what does imaging show us? Mammogram and sonogram are typically what women are getting. It's going to show us the breast, and the sonogram is going to take a close look at the lymph nodes as well. Any abnormality that we see that deems the lesion suspicious, okay, and there's a number of factors that we look at. We look at the shape of the lesion. We look at if there are these things called calcifications, which could happen for a number of reasons, but cancer happens to be one of them. If we look for other things called architectural distortion, where it kind of looks like the tissue's being sucked into the area. We take all these factors into consideration, and if it's suspicious, we will perform a biopsy of that area. Now, if the lesion is found on an ultrasound, we try to do the biopsy under ultrasound guidance. So with the radiologist will have the ultrasound probe in one hand, looking at the lesion. We'll watch the needle actually go into the area of concern, and then they fire the biopsy, and it's essentially ripping out a small piece of that tissue. If the lesion's found on mammogram, as Tanya had, she had what we call a stereotactic biopsy, where it's done, the biopsy is done in the same way, but in a mammogram machine while the patient's under compression. After the samples are removed, a lot of times the radiologist will do a mammogram of the samples to make sure that, yes, we see a lot of calcifications here, we got the site that we were looking for. And then finally, after the biopsy is performed, the radiologist is going to place a little metallic marker right where the biopsy was performed. This is very, very important that this is placed. I've had a lot of patients who've refused to have this clip placed because they're worried that it may cause, they don't want anything foreign inside of them. The clip is extremely tiny. It's very hard to even see with your naked eye. It's never caused any problems for anyone. It's not going to set off metal detectors or anything like that. The reason we place that is because after the biopsy is performed, the area that we saw that looked suspicious now is going to look completely different after ripping out tissue and then healing from that. And we need to know if there's cancer there. If we do get a cancer diagnosis, I need to know as a surgeon where it is. And so that clip tells us. And just to touch upon something that Douglas said earlier, some cancers are treated with medication first. And so if we're giving medication first and it shrinks whatever tumor was there, the only marker that we have there is that metallic marker to know exactly where we did the biopsy. So it's very important that that's placed.
And how do you know when it goes to the lymph nodes? The lymph nodes kind of travel throughout the body.
So two ways. Sometimes we know before we operate. Yeah. We'll see that a lymph node looks big. We look at the morphology or the shape of the lymph node to determine if it's suspicious and warrants, again, another core needle biopsy of the lymph node. Now, sometimes the nodes look completely normal, but that doesn't mean that the cancer has not gone to the lymph nodes. Cancer happens on a microscopic level, and an ultrasound is not going to pick up microscopic disease. So that is something that's figured out at the time of surgery. We have a new technique which is largely replaced the old technique where we just go ahead and remove all the lymph nodes if you had breast cancer. The new technique is called sentinel lymph node biopsy. And this is where we essentially create a map of the lymph nodes at the time of the operation. So the patient would lie down on the table, would go to sleep, and I would inject a radio tracer into the skin of the breast, and that radio tracer will travel through the lymphatics to the lymph nodes under the armpit. And it goes to typically 1 to 4 lymph nodes under the armpit. Most people have anywhere between 10 to 30. And if we look at the lymph nodes, if I make an incision in the armpit and look at the lymph nodes, it looks like a cluster of grapes. There's no rhyme or reason to it. There's no order that's saying this is how the lymph is traveling. This is how the cancer is spreading. That tracer tells me which are the first few lymph nodes that cancer would spread to if it were to spread. And so I'm able to identify those in the operating room. I just remove those lymph nodes, and then we have them analyzed by a pathologist, and that's how we tell, did cancer go to the lymph nodes or not? If those nodes do not have cancer in them, then we can safely assume that the rest of the lymph nodes do not have cancer, and so we don't do any further surgery.
That's very interesting. Would you say that once the cancer is in the lymph nodes, that increases the chance of it having spread to another place?
Exactly. Yes. If cancer has gone to the lymph nodes, it's at a higher stage. It's more likely at that point that it's also in the bloodstream. Not necessarily from the cancer in the lymph node, but from the cancer in the breast. Because if it got into the lymphatic channels, it could certainly make its way into the bloodstream.
And when is it an indication for surgery? Are we looking at a total mastectomy? Are we looking at a simple, how do you make that distinction, and what kind of surgery I'm going to have?
Got it. So let's start with the indications for surgery. Unfortunately, in 2024, any patient with breast cancer who's healthy enough for surgery needs surgery. And there are many reasons for this. Even if the patient received chemotherapy beforehand and it looks like everything completely melted away and disappeared, we still need to prove that that happened on a microscopic level. And so surgery is always indicated for breast cancer. But fortunately, in today's day and age, patients have options for surgery. The two main options are, number one, the old-fashioned way, where we do something called a mastectomy. This is where we remove about 99% of the breast tissue, most of the times including the nipple and areola, and then a plastic surgeon at the same time will perform the reconstruction. This is the bigger surgery. Again, it's the old-fashioned way of doing things, and it's still an option today for all women with breast cancer if that's what they choose to have. But fortunately, now we have a smaller surgery as an option called breast conservation. This is where the patient gets to keep their breast. Now, they have to meet certain criteria for it. They can't have a very large tumor that's taking up half their breast. It has to be a particular size. But this is a same-day procedure. As I mentioned, the patient gets to keep their breast. Complication rate is low, recovery is fast, and all you are having is the tumor removed with a rim of negative tissue around it. But the deal here is that if you are getting a lumpectomy, you have to get, in most cases, radiation with it. Radiation is given anywhere between 1 to 5 weeks typically. We've cut back a lot on the amount of radiation we give patients. It's usually very well tolerated. The most common side effects I see from radiation, it's not going to make you lose your hair. You're not going to be radioactive. You could hug your family members. Fatigue, a lot of patients will be tired during treatment, but that goes away. The other main side effect I see is a sunburn-like skin reaction, but a lot of times that goes away as well. So radiation's very well tolerated. In fact, the number one complaint I get from patients about having to go for radiation is that they have to drive to the center 5 days a week for 3 to 5 weeks. That's the hardest part about it for a lot of patients. So those are the two main options. Now, the chance of a cancer coming back in the breast after mastectomy is not zero. Okay, we can never make it zero. It's about 1% over the next 10 years. With lumpectomy and radiation, it's more like 5 to 10% over the next 10 years. So it's a little higher, but still very low. But the reason that we can offer patients both options is because no matter which one they choose, their survival from the breast cancer is going to be the same, and it's going to be excellent.
These are some differences, as I notice as years have progressed, there has been changes in how you do surgery with patients who have had breast cancer. What do you, are you still doing the saline implants for reconstructive surgery? And is reconstructive surgery just something that you're doing a lot of?
Right. So I'm not a plastic surgeon, but I work with a lot of plastic surgeons. They are still doing saline implants, silicone implants. One type of reconstruction that's really caught on as of late is actually just a flat closure, where women feel they don't need to have another breast on that side. And I still work with a plastic surgeon in that case just to make the chest wall nice and flat. Usually smaller breasted women go with that option because it's not a big difference to them. One option that it's a very big surgery that's catching on more is something called autologous tissue reconstruction. And this is where the plastic surgeon will actually use your tissue to create the breast. So you won't have an implant or any foreign body inside of you. They will typically get the tissue from your belly fat, and fashion a new breast out of it. It's quite an incredible operation. It's a big one. If you're having both breasts removed and having this tissue transfer performed, it could be up to a 12-hour operation in some cases. But the results are fantastic. It looks a lot more natural, and it's more durable. You don't have to worry about implant rupture down the road. If you gain weight, the breasts gain weight with you. If you lose weight, same thing, because it's your tissue. So those are the main ways that plastic surgeons are performing reconstruction today.
Wow. Doctor, is it ever a time where you recommend a double mastectomy? Tell me the instances.
There are two scenarios where I go out and recommend a bilateral mastectomy. One scenario is if it's a relatively younger patient who has a genetic mutation that puts them at a very high risk of getting a cancer again in the future. Another one is if the patient has cancer in both breasts and they're both really large cancers. Other than that, that is a decision that is completely up to the patient. A lot of times, if I don't feel that they need to have it done, I won't even bring it up. Because if you have cancer in one breast, the utility of removing the other breast, a perfectly healthy, normal breast, does absolutely nothing to improve the patient's survival from the breast cancer that they already have. And what patients, what they'll think typically is, well, I don't want to go through this again in the future. I want to be done with this. I like the idea of never having to get a mammogram again, so I want both breasts removed. But I'll tell them, well, let's say we did a beautiful surgery on the cancer side, and we did a great surgery on the contralateral side, the side that does not have any cancer in it. And heaven forbid, you have a complication on the side that didn't necessarily need to be removed. And now that delays you getting the chemotherapy that you might need, or delays the treatment of the optimal treatment of the breast cancer that you already have. You have to think of it in those terms as well and take that into consideration.
Thank you for that. I'm going to ask if Miss Eartha Washington would share, once we are cancer survivor and have gone through surgery, and have dealt with the onslaught of chemotherapy, radiation, medication, and all that we've been talking about, is going home and living in the community with friends and family. Would you share with us what you're doing on your end and what you're involved with living as a survivor?
Yes. I'd like to tell this story twofold. I'm not a breast cancer survivor, but I am a very high risk for breast cancer. In my mid-30s, I discovered a lump in my breast, and a friend of mine took me to Sloan Kettering in Manhattan, and they sent me to this institute, Gutman Institute, for a mammogram, because at the time, you couldn't get a mammogram unless you were 50, and I was only in my 30s. So I went to the Gutman Institute, they did a mammogram, and then I was sent then for a biopsy of the breast. And then I was told that I have very dense breasts, so I could develop cancer. The lump that was there was not cancerous at the time, but I could develop it as I aged. So from mid-30, I've been taking mammograms up until now. And what I do, even though I take the mammogram, I also have to take with it an ultrasound to make sure that nothing is developing there. So that's my story there. So I advise everyone, no matter how old you are, continue to do those mammograms. I had to do them twice a year for a number of years, and now I only go once a year. But each time I do with the ultrasound to make sure that nothing is developing. And then at age 45, I was having problems with being anemic all the time. And I went to, I don't know how many areas to find out what was happening with my blood. So finally, I went to this hospital, and they put me in this big round tube, and they told me that I had a mass in my liver. So I asked what could be done. And the doctor said to me, we could do surgery. So I asked then, you know, what will happen if you do the surgery? He said, well, we can't guarantee. It will be 50-50. And I said, what does that mean? He says, we could lose you on the operating table, and you may survive. So I said, well, what if I decide not to do the surgery? What can I have? So he says, the only thing we have now is, for your type of mask, is radiation. So I did radiation for 6 months. And then when I went in for my last session, and I was told that the liver was regenerated again, and there was no sign of the mass. And here I am today. So sometimes we have to make decisions that may not seem, so this is what I did. I was so afraid. I had 3 young sons, so I went and I took out an insurance policy for $200,000, and I asked my mom, if I don't survive, I want you to take care of my boys for me. And she didn't have to, and here we are today. Thank you.
Ms. Barish, I know that, oh, sure. Yes,
This
please.
is a sort of a crowd that I want to make sure we have a chance to learn something specific. We mentioned, Black patients, African American patients are at higher risk, and there's a few reasons. One, there is a higher predisposition of some genetic mutations, so that's important. 2 is there's a higher breast density in many patients. And we're learning more and more about breast density, and now it's New York state law that they have to report your breast density on your mammograms. And that's because breast density increases both your risk of having breast cancer because the breast is more active, but also makes it harder to see that there could be something there. So just like Eartha had, it's very appropriate to have more than a mammogram in those situations. Sometimes it's an ultrasound, sometimes an MRI, but it's often not just a mammogram. So, if you're following the primary doctor who's doing a mammogram and you're seeing on your reports now it's saying your breasts are dense, this is something that you can discuss with them, say, what does this mean? I was just somewhere where they said I might need a little bit more than a mammogram. The other is that the types of breast cancer may have a slightly different environment of the cells around the cancer cells. And this is something that's really important because we shouldn't assume that because, of some social reason that breast cancers are different. We should always seek to understand if there's some biologic differences. So it's very important that Black and African American patients participate on research studies with everyone else. So we can understand, because there might be slightly different treatments that are more effective in this group of patients, and we don't want to not know because we didn't ask. And I think there's lots of reasons why people are nervous about clinical trials. But if you look at clinical trials, women who live longer who are on clinical trials, they do better. Clinical trials do not mean that you're going to get a sugar pill. In oncology, we don't have those type of studies, almost never. It could be just a study to learn about your breast cancer in more detail. Or it could be a study where you could get access to a new treatment in addition to the standard treatment. And so we need to sort of make sure everyone's included on these studies so that we can learn, because there may be differences in the biology, the immune cells, the body's response to the cancer, and if we don't know it, we won't be able to better treat, because this group of patients are at higher risk for cancer coming back, and that's the thing we need to prevent. So in America, no one dies from breast cancer in their breast. Right? In other countries, breast cancers may get huge and get infected, but that's not what we're dealing with here. We're dealing with preventing that breast cancer from coming back outside of the breast, somewhere else in the body where it's not supposed to be. And that's why women who have their tumors removed, you may say, Dr. Michael got negative margins. There was nothing in the lymph nodes. Why do I need to take any medication? And it's because medication is critical, because it's what's going around your whole body to catch that cell that escaped, even if it skipped the lymph node, so it doesn't come back somewhere else like another organ, because that's where the problem is. So I think screening is important, recognizing that you may be slightly different than your neighbor in terms of breast density and trying to be active about that, and knowing that everything we can do to contribute to understanding why some groups of patients might do slightly different so that everyone can get the good treatments.
That's wonderful.
May I just add something else too? As a result of my continuing with my mammograms and ultrasound, in 1994, I, along with 3 other breast cancer survivors, we came together and we organized Sharing and Caring, a cancer support group in 1994, and it's based in Queens, and we are a cancer support. We offer cancer support services for women and men who are diagnosed with breast cancer, and now we have gone to other areas. We also offer services for ovarian cancer, colon cancer, prostate cancer, and we recently had a case, myeloma, another form of cancer. And these are all men, and they're all coming to us for services. So as a result of what happened to me, and we get younger and more younger women, especially African-American women, who have been diagnosed much earlier than the time that is listed for mammograms. So we are there, and we hope that we can help get a cure for this disease.
Thank you for that. Yes. Ms. Barish, can you tell us about the Hewlett House and all of the wonderful things you're doing in the community with providing wigs for the women who have lost their hair during the chemotherapy and et cetera?
Well, Hewlett House is the most incredible place in the world. I love it so much. It's a 387-year-old national landmark, the last farmhouse left in Long Island, and we have turned it into a home. With a home environment, we have a wig room where we're totally free service. Anyone who enters our doors, we give out bras, wigs, bathing suits, hats, sweatshirts, you name it. We have social workers that all volunteer their time. We have Tai Chi, we have Reiki, we have meditation. I have a doctor on board who is a psychologist with an oncology background who volunteers his services. We have a children's room. We have a media room. We have a room for teenagers. Teenagers, unfortunately, have no place to go. And we have no curtains on the windows because I believe that the light and the sun should always shine in. We want it not to be dark. We have a kitchen, dining room, living room, and this year we're starting a nutrition class and a cooking class. The gardens are magnificent. We have an art center, and in the art center, we have an area for banking. People who are just diagnosed or ill or sick, they can't fill out something. They need help with that. We work with a group of attorneys, pro bono. They will come at different times of the year, and they'll answer questions about, you go into a hospital, emergency room. You're so upset with your own situation, you can't read all that stuff on the wall. What do you sign? How do you protect your children financially, protect your home? What's a proxy? Who should you give it to? What should be in there? And this is all a free service. It truly is an incredible place. It's warm, inviting, and we're very fortunate with many of the hospitals that we work with. We're able to get you an appointment to be screened within 24, 48 hours. We're able to call up and get you an appointment with a doctor. My specialty, unfortunately, is fighting the insurance companies. So we've written legislation. We can tell you who to call, if you're covered, if you're not, and what's the right questions to ask. We work with environmentalists. I am an environmentalist and believe that we need to teach our kids. We work with all the schools to come and do all their community service. We teach kids how to learn to do resourcing, what's important, what's not. And I think one of the main things that we've learned to do is have a rapport with our doctors. Doctors are special, but so are you. You need to be your own advocate. You need to fight for what you believe in. You need to ask those right questions. And if you're not happy, then you need to move on. And we have learned that. We don't always have to agree with someone, but we need to know why we don't agree. And I do tell people to be wary and be fearful of our internet. I know technology is a big issue, but when you get on the internet and you're looking for a particular cancer, it's not about you. Your name is not in there. It's broad. So don't run out and say, how come I'm not on this antibiotic? I'm not taking that treatment. We're each individual and we're each genetically, different than the next person. Ask questions. Ask your doctors. And you'll be fine. Today, it's amazing. And I am a believer in clinical trials. And I will tell you one quick story about a lady whose husband carried her in. She was given 3 to 4 weeks to live. And she went into the living room and talked to other patients. And I got on the phone. And I started calling different places about clinical trials. And I spoke to someone up at Yale. And this gentleman said, we have a clinical trial. I'd like to speak to a family member. And I put her husband on the phone. And they left the following day. And that was 10.5 years ago. She is cancer-free. She saw her 2 children grow and get married. You can call it a miracle or whatever you want to call it. It's about hope and taking a chance. And that was a clinical trial. And then she was told, you'll have to be on this clinical trial for life. Guess what? She said, as long as I'm cancer-free, it's okay. Things do happen. Thank you.
Thank you for your great work. We had a wonderful segment with the men in the other area, and Reverend Stanislaus, I'm understanding, is in the audience. Is he still here? Oh, would you come to the podium? I would like you to come and to share a little bit about what you spoke about during the forum with the men. Would you please come? You can have a seat right here amongst this distinguished panel.
Okay. Hi, distinguished panel.
And tell us about what you shared.
Well, basically, I just told him the story, my journey of getting prostate cancer in 2020. And as the story goes, I was sitting in the living room, and I said to my wife, it's the pandemic, so I'll wait until next year to go to the urologist. I'm sure I'm okay. And she said, no, you won't. You're going to go. And I said, no, I'm not. It's the pandemic. So for the next 3 days, she kept saying to me, you should have gone. You should go. And I figured either I'm going to have 365 days of that, or I'm just going to go. So when I went to the doctor, my PSA went from 1.8 to 3.9 in 1 year, realizing that in African-American men, it could be more aggressive. And so I got one consult from the doctor who said he detected something, but I didn't feel comfortable with that because he said to me, tomorrow I want you to come in, take these 2 pills, and I'll give you a biopsy. I didn't even know what he was talking about. And so it's important that we take control of our bodies and we ask the right questions and we do the research. And I found a doctor in Manhattan, Dr. David Samadi, and when I went to him, he took me, like the young lady was saying, step by step. He understood my story, and he said, okay, we're going to do this, we're going to take this step, and he explained everything to me. And I just knew he understood what I was going through. He even I went through robotic surgery, smart surgery, he called it, and he kind of explained everything to me about the surgery. And so I didn't understand it all, but I really respected the fact that he sat and he went through it. And he said, you come to me so that I will save your life. And I had to remind him, I said, your hand's in God's hands, right? And he said, absolutely. And so going through that experience, I got to be honest with you, the darkest side to that, and sometimes men don't talk about that, is that when he said to me, you have cancer, and I was alone, when I went into the car to drive home, that's really when it hit me, because I was saying, I pastor a church, I'm raising my family, Lord, what are you doing? You know, those are the real sides, something people don't talk about, that you had those moments. And I said, why me? And like within my heart, I felt, why not me? All right, and perhaps, like Sister Washington said, could be used to do something on behalf of other people. And I see that God has blessed me with being able to share the story and to encourage men that early detection is most important. And so even if you don't have a nagging, no, I shouldn't have said that. Even if you don't, even if you don't have someone constantly pushing the issue, it's important to go to the doctors every year to get checked out. That's most important. And so I did the robotic surgery, and I'm here to tell you that it's been the greatest thing of my life to come through that. I've changed my lifestyle. I eat healthy. There's some things we cannot control. The fact that I'm African American, perhaps it's genetics, my age, as I'm arriving towards 68, I'm going through these things, and things are shifting and changing. But I've changed my diet. I exercise every day. My wife is with me when we exercise. We're both retired, having a great time. And just watching what I eat, plant-based, a lot of those things, I'm doing all that I can to take care of myself. And also, I go to Dr. Samadi every 6 months. So things are going great. I'm here to encourage. There is life after cancer. There is life after cancer, and a great life after cancer. I have 5 grandchildren, 5 granddaughters, and 1 grandson. I have 4 daughters, and I'm going to leave you with this. Telling my 4 daughters about the fact that I was diagnosed with cancer was probably the hardest thing to do. I told my oldest daughter, who's very emotional, she screamed, oh my God, we got that. Number 2, I told her, she was real quiet, she started journaling about it. I'll skip number 3 and go to number 4. She's now a lawyer, and she said, all your paperwork, is it in order? That's who she is. And then number 3, as I was going through this process, she was entering medical school, decided to become a urologist, and now she's in surgery as a resident in urology. The challenge is that when she was going through medical school, I was retired, and we were pretty much at home together. So I think I was her guinea pig. She kept checking everything. And so I have my own private lawyer and my own private urologist. I'm great. All right? That it? Okay.
That's a good story. Can you tell us, for a lot of the audience, what is, the doctors or you, what is a prostate? What does it do? For a lot of people that hear prostate cancer, obviously it's men. But what is a prostate and what does it do, doctors? I know you're a breast surgeon, and and is there a connection when you talk about prostate and breast? Is there a
Doctors,
connection?
I have a question. I was told that, and I just really searched this out, and I'm sorry I went on the internet and I found it, but and it said that if your mother has breast cancer, a son will be at high risk of getting prostate cancer, and that just confused me. Is there any way you can speak to that?
Yeah, because, I'm sorry.
So breast cancer has changed the treatment of many types of cancer, including prostate cancer. Well, breast cancer has changed the treatment of a lot of types of cancer, including prostate cancer. That's why, sometimes when we're doing research on one thing, we help out another group. And it turns out that cancer genetics were really born in breast cancer. And BRCA1 and BRCA2 were a big breakthrough, understanding these two genes that were so important in what was thought to be primarily a syndrome of breast cancer and ovarian cancer. And a huge amount of research was done, and when a woman is diagnosed with breast cancer, and if she's found to have that mutation, everyone in her family can be tested for free. But it does also play into, as you understand more about this, for example, BRCA2. Women who have a BRCA2 mutation, men, as I mentioned, men still in their family have a very low risk of breast cancer, maybe 4%, but they had a quite high risk of prostate cancer and a slightly higher risk of pancreas cancer. So it is true that having a family member, if you have a genetic mutation that puts you at your risk for breast cancer, which makes up about 20% of people, most cancer is not genetic. But if you happen to have that in your family, there is risk for both prostate and breast in the same family.
Thank you.
Yes. You can jump right in there.
So, Dr. Marks, is this, so when I was going through, you had me do a Zista genetic test. Can you kind of talk about that and the importance of having that test done?
Oh, sure. So, genetic testing is really very important for a few reasons. One is because when you're diagnosed, if you're at a younger age, it may impact what surgery you elect to have. So what Michael was saying is, if you knew that you had a genetic risk factor to have a high risk of just a different breast cancer in the other breast, you might opt to do a bilateral surgery, especially at a younger age. So that's reason. Another reason is because we have medical treatments that only work in patients who have certain genetic mutations. So I can offer a patient a pill instead of maybe chemotherapy who has a certain genetic mutation, and I won't know unless I test them. And also, of course, what goes out without saying is that, it's important for your family, right? If you're diagnosed with breast cancer and you learn that you have a genetic risk, then you can screen patients, people in your family, doctors can screen patients at earlier ages. So as Michael was saying, the guidelines, and as Irina was saying, some government guidelines say 50 plus, but no breast oncologist guideline suggests that, no breast surgical guideline, no gynecologist guideline suggests that. We all suggest 40. But that's in the well woman without an impressive history. Otherwise, it's 8 to 10 years before the youngest member of your family, or if you have a genetic mutation, you can screen, you should screen, for example, for BRCA, beginning in your mid-20s with MRIs before mammograms even pick up anything. So genetic testing helps you help your family. It helps you help yourself with what surgery you might get and also what medicines you might receive. It takes, about 2 weeks to get the best genes back and then 4 weeks for all the genes. And it's done with a tube of blood or a cheek swab. So it's no invasive test. You don't need to get another biopsy for it or anything bone marrow. Some people think they get their bone marrow checked. Your bone marrow is fine.
Into that, isn't it more prevalent if you first generation, if you had maybe a mother who had breast cancer, is it a high incidence if you first generation relative versus a distant relative?
Yeah. So about 10% of women diagnosed with breast cancer will have a genetic mutation. About 20% will have an impressive family history. An impressive family history is a first-degree relative or 2 second-degree relatives. Having multiple second-degree relatives adds up, but having a first-degree relatives matters more, and that's in part due to the fact that you share more genes with your first-degree relatives than your second-degree relatives. More specific genes, but also more gene profiles.
Yeah.
So family history is important.
So to my question I asked originally was, where's the prostate for men? We kind of switch gears there. We go breast and then prostate.
Yeah.
We're back at the prostate.
Sits next to the bladder. Okay. And it makes fluids that are helpful for some lubrication in some of the genital urinary tracts. Full disclosure, I'm not a urologist or a surgeon, but the prostate it does produce seminal fluids, which help with fertility.
Yes.
One issue that comes up, so breast cancer and prostate cancer have some similar psychosocial themes as well. So We talked here about, I'm a medical doctor, so I get the patient sometimes before surgery, if I'm treating them before, sometimes after surgery, but there's a psychosocial that comes with doing operations on someone's breast, and that's why breast reconstruction is so important, and most women do elect to do it and should be encouraged. It's covered by insurance if they need a mastectomy to get reconstructed, or if they want to have a lumpectomy and need to have some revision of the breast, like a reduction to make everything symmetrical. So there's a psychosocial component of that. And then with prostate cancer, there's a psychosocial component too, because when you operate on that area, there can be issues with sexual performance. So there's these kind of themes that run in between it, and that's because the prostate is located near a number of nerves around the bladder and the penis.
Yes. So with diagnosing prostate cancer, I know that there is, maybe you could speak to this, Reverend, in terms of how were you diagnosed? It was a digital examination that they found some kind of mass or lesion, or how were you diagnosed?
Two parts. First, it was the blood test. I received my PSA numbers, which is a prostate-specific antigen, which is specific to the gland, to the prostate gland. And so when my numbers went from 1.8 to 3.9 in a year, that seemed aggressive. And so I did the test again, but Dr. Samadi decided to do the PSA test first and then do the DRE, the digital exam, which I tell you the truth, in speaking to men, that's the one that they tend not to want to get involved with. So I tell them take the blood test first, and if it seems to be going in that direction, then perhaps the doctor will do a digital. But it's important, I've learned, for the digital to be done second, because if it's done first, it can increase the numbers of the PSA, and it's like a false reading. So he did that, and then he said, well, after the digital, I do sense that there's something there, that the tissue itself was a little hard. And so he gave me, he said a biopsy, but before the biopsy, he did an MRI so that he can actually see exactly where the cells were. Because sometimes, if you just do the biopsy, it's like they going into the prostate, and what if they miss certain things? So he knew exactly where it was, and so he went to that area, and then he gave me a staging. He looked at the tumor, the nodule, the lymph nodes. He said if that was clear, there was no metastasized, so it was, everything was right there in the prostate. And so he said, in terms of treatment, would you like watchful waiting? And I don't believe in that. For me, okay, might be for some men, but for me it was like having a tiger in your bedroom hoping that he doesn't come out the room. So I said, get him out now. And so I opted for robotic surgery. And he said he was aiming for three things: to remove the total disease, to protect me from incontinence and erectile dysfunction. And I got to be honest with you, I said, well, does erectile dysfunction have to be so low on the list? And he said, and he explained to me that's the order of it. And he said because of the nerves around the prostate gland, and doing robotic surgery, had to be very careful not to touch the nerves. And he's sparing the nerves. And I'm going to say, honestly, he did a fantastic job. I'm healthy in all three areas. And so I say, when I speak to a group with so many women in the room, and we talk about prostate, it's absolutely important. I think, doctors, I found the key to get more men to go take the test. All the women have to do is say, I heard that your PSA level will increase if you're being intimate with me. So until you get it, we can. That solves the problem. They will go get it, come back with the paper to prove it. All right.
I'll try that. I'll try that. That's good psychology, Reverend. So tell me the incidence. Can you tell us a little bit of the incidence of prostate cancer?
So prostate cancer is the most frequently diagnosed cancer among men in the U.S. The incident rate of 114 per 100,000 men. It has the second highest cancer death rate for men at 18.7 deaths per 100,000. In Nassau County, prostate cancer incident rates are higher than New York State average, and Black residents have higher rates within the county. I did want to say, and I don't know if it's leaving us off on a good note rather than some of the negative ones, Nassau County has phenomenal access to care. We have some of the world leaders in medical care delivery. We have amazing technologies that are available, and we have amazing screening potential. And at times, I often wonder with some of our statistics, because we're very statistics heavy, that access to care is actually contributing to the fact that we are detecting much earlier, so survival rates are much better off because we're having better treatment options. So I do want to emphasize the fact that we do have incredible medical providers, and this panel is a testament to that fact. We have incredible support, community support services and organizations. There are the Hewlett House, there are other support groups that are available in our communities. There are community-based organizations, faith-based organizations, and of course the Nassau County Department of Health. For everything else, there's MasterCard. I think for everything else, there's the Nassau County Department of Health, whether it's the statistic rates or whether you just want to know who to turn to. We do have the Health Equity Resource Center that's located right here at 40 Main Street. So we're always able and willing to help. But there is help out there. There are resources out there. So we're really hopeful that you will take that leap and get that screening for yourself first and foremost, and also for your loved ones and family members. So thank you.
I just want to ask one last question for Reverend. That meeting that you had with the men in the other room, what do you think was the common theme? What brought them together? What brought you guys together in order to really talk seriously about this and how we can really affect change in the county, in Nassau County and beyond?
You know, it was a strange thing that happened, and it happens when we're talking, when men are just together, that we were able to deal with what prevents men from wanting to go to the doctors and fear, because men in those groups don't really like to admit fear, but they were able to open up and say, I've experienced this, and so many men in that group are dealing with or has dealt with prostate cancer, but they were able to say that in the darkness of the night, when no one else is around, how they did cry, and they did wonder, is this the end? And those are real feelings. You know, is this the end? What is the quality of my life beyond this? Will this return? And sometimes an important part would be that the small groups, the support, which I didn't feel I had. I had a great medical experience, but I had to go out and find a group that I can sit with and talk to and say, I'm feeling this, I'm afraid of this, I want to live, you know, I want to be around, what are these things I can do? And they did say, well, there's some things I can control and some things I cannot control. And the things that I was able to control was make sure I'm exercising, I changed my diet, you know, I keep my mind positive, I stay focused on what is right, I love my family, and I kind of stay away from all that negative stuff, and I found myself just doing great, you know? And so exercise, eating right, watching the sugar intake, and I don't know if that's right with the medical profession, but for me, I look under every label, I see too much added sugar, I said, it's not for me, the sugary drinks, the stuff, the fried meats, the stuff like that, the red meats, I'm just very careful about what I eat. And I've found that in terms of the 5 defenses of the body, based on the food that I eat, it keeps me feeling great, it keeps me feeling healthy.
What are you eating? No more fried chicken for you?
No. I'm going to be honest. I was raised in Brooklyn. My mother, the only thing she really knew how to cook was fried chicken. Yeah. So it's almost like a comfort for me to go back. So I was telling them earlier that when I'm driving home and I've had a tough day at the church or what have you, and I'm passing that Popeyes, I can feel it. It's calling me, man. It's calling me. You know, it's like taking me back to. And so I call my wife and I say, I'm having that moment. She said, keep driving, baby. You're going to make it. And I kind of get past it. So, but yeah, I just watch my diet and I'm exercising and I'm staying positive, and I'm just living
Still
each
haven't
day
said
long.
what you're eating.
Well, you know,
Plant-based or?
Plant-based, a lot of fruit and vegetables, and there's a book by Dr. William Lai, and he says, based on the 5 defenses of the body, he gives a list of all the fruit and vegetables that you can eat, and I find kiwi is in each one of those categories, raspberries, blueberries, berries, and fruit. I mean, it's just amazing, and I've found that, and I'm gonna leave you with this, that before the prostate, I started getting aches in my knuckles, and I figured, well, that's just part of it. I'm getting there, but I don't have that anymore. It's the strangest thing. And Dr. Samadi tells me, just keep doing what you're doing. He's doing what he has to do for me, and I'm doing what I have to do for me. But just to give up and say, this is it, I'm telling you, you change your diet, and you change your life. I believe that.
Yeah, that's great.
All right, doctors.
That's really good.
Perfect. Thank
We're coming to the end, but I want my guests down, Tanya, and we want to chime in on that diet part, because I'm big on diet. Have you changed your diet since?
Yes, I have. Sugar is not my friend at all. I've never been a big red meat eater, so that's not an
Prevention,
issue
yeah.
for me. But yes, your fried foods are completely out. And for me, I have other concerns like with acid reflux, right? So I don't eat spices. I don't eat my favorite, which is bread. I can't have bread anymore. Oh gosh, I miss bread so much. I'm sorry. So I'm limited on what I can eat, but you find ways to make sure that you can eat and that you're eating healthy. For me, mentally, because I had to find a reason to justify why I have cancer without blaming. And I had to realize that I had spent years, 48 years of eating incorrectly. I've never been a big person. I'm not quite sure why, because I eat a lot of bread, but I've never been big. But I had to really look at that, right? My sugar intake was my main meal prior to being diagnosed with cancer. And so you have to eat right. Deputy Director, I have to get ready to go because, I have to head back over to Union. I got my notification, right? But I want to leave everybody with this one thing. If you don't take anything from everything that you've heard today, take away the fact that you need to advocate for yourself. And that starts with screening, right? So cancer of any sort is not a death sentence, but what is not being screened and not being your own advocate for your own health. So eat right, pay attention to the signs and the warnings that your body give you. And because not everybody's going to have a success story like me, right? I had no chemo. I had no radiation, but what I did have was the mindset to go get checked and then advocate for my health and being put in the right position with some of the great providers that I have. And so when I tell my story, there's certain names that I mention, and that's Dr. Logman, Dr. Marks, and Dr. Kilgo. That's my breast surgeon, my plastic surgeon, and my hematology oncology specialist. This man right here, Dr. Marks, to see you on the program, it warms my heart because I give him credit for knowing my story, paying attention to my story as Tanya, not as another patient, and making my plan to save my life.
As you exit, we want to thank you for coming. I know you have to leave, but we thank you so much for coming. As we're ending, I just want 2 words from all of our panel, just to leave us with something, just a couple of words as we end.
So I couldn't have phrased it better myself. I think that was the best public health announcement that we could have had, both from the Reverend and Tanya. Definitely promoting healthy lifestyle overall, while not directly related to breast cancer, but importance of vaccines, routine healthcare screening, staying active, eating well, maintaining a healthy weight, limiting alcohol, drug use, taking proactive steps, both individually and collectively as a community. I think we've heard a lot of both individual stories, clinical, medical care, population health perspective, but I think it's the community coming together and supporting our families, our residents, and that's something that will contribute. Together, we can definitely work towards better health outcomes overall for all of our Nassau County residents. So that's what I'll leave you with, and thank you.
So you asked for 2 words, so I'm going to give you 2 words. Get screened.
I agree. Get checked.
Yeah, I mean, I think I would, I don't know if I have 2 words. I would just want to say one thing, though, that these
Doesn't have to be 2
these
words.
patients are so exceptional. Obviously, I'm biased for my patient, but, become an expert. Hey, that's 2 words. Like, you should walk out of a doctor's office feeling like you know what's going on. Everyone up here, these patients, they know what's going on. You sound like you're an expert. You know everything. You know the words, all the terms, and it's because someone taught you and you researched it. And so that's really important. So, become an expert. Don't be afraid to learn something.
Mm-hmm. I'd just like to say, pay attention to your body. When you feel different, act on it.
Rev?
Say early detection. Early. Okay.
Well, we hope you enjoyed all that was said. We need you. You can have a hand clap to that. We need everyone to complete the evaluation form. So you have it in your folders. Look to see if you have it. If you don't have it, raise your hand. We can give you an evaluation form. Okay, so we need you. If you don't have one, just lift your hand up and we will provide that for you. Okay, we have a hand here. Anybody in the back can give? Okay. Yes. I'm Dr. Janine Cookerod. Thank you so much for this. We're going to have our Deputy Supervisor, Dorothy Goodsby, to say something to us. Thank you.
How many of you enjoyed the program? Wow, how about that? And I want to tell you, this was fantastic. It's really, really something that everyone can take home with them. And I thank all of you so much for all that you've given us. And certainly, I'm so happy about this man here with the men, because that's one thing that's been bothering me, the fact that our men do not go and take care of themselves. I've seen so many of them, I've talked to so many of them, but now I think I have you involved with something else, because I didn't know exactly who you were at first, but I do know you now. I've come to your church a couple of times. So since I've been there, and you have men in there, I'm sure you're going to start working on them. All right, because we really need that to happen. You all have just been fabulous, really.
Yes.
You really have done a great job. And certainly you have helped people who really need it. And we would have had more people, but unfortunately for us, we had a big person, young man, who lost his life. And because of that, that church, where I go to church too, was so full they can't all get in it. But, you're here. Thank you so much, and we'll be looking for you again for the next time. So, and I do have citations for each of you so that you'll have something to remind us of you and you remember us.